Thank you to everyone who just joined the ONC Pulse Community Listening Session and Workshop. We will be starting in another minute or two. Great. Thank you to everyone who joined the Office of the National Coordinator for Health Information Technology's Patient Unified Lookup System for Emergencies, or PULSE, Community Listening Session and Workshop. We're excited to have all of you today. My name is Chrissy Celentano. I'm with EMI Advisors supporting today's workshop. Before we get started, a couple of quick reminders. Please mute yourself if you're not speaking. You can use the chat for questions or comments at any time, and the meeting materials will be shared afterwards. The agenda for today will have some opening remarks from ONC's National Coordinator. We will review the workshop objectives, and then we'll spend a little bit of time talking about the emergency management landscape and background on Pulse Initiative and Pulse Community. Following that, we've planned a state panel with 3 states who will share their Pulse implementation experiences and perspectives. We'll pause for a brief break, and then we will go into smaller group breakouts where we'll have an opportunity to discuss the ideal state, challenges, opportunities, around and considerations around Pulse Community and the Pulse Initiative. And then we'll come back together for a conversation with everyone to close out the day on the future of the Pulse Initiative and Pulse Community. And finally, we'll wrap up. Before we go further, I just want to quickly acknowledge the team that will be supporting today's call. Rachel Abbey from ONC is the Pulse lead who will be supporting the call, and then the EMI advisors team. You can see our faces on the screen and you'll be hearing from us. Rim Cothran, myself, Chrissy Celentano, Kate Kieford, and Brenda Kirkumar. If everyone on the line could please chat in your name and your organization, it'd be great to see who's on. And with that, please go ahead and continue to chat in your name and your organization. And with that, I will turn it over to Mickey Chapathy, the National Coordinator for Health IT, for opening remarks. Over to you, Mickey. And Mickey, I don't know if you're muted, but we can't hear you yet.
Yep, sorry. You would think I'd get used to the Zoom protocol here, but occasionally get a fumble. Thank you so much. And thank you everyone for joining today. I really, we at ONC really appreciate it, and we look forward to the discussion. We know access to an individual's health information is essential to care, and equally, if not more, essential during an emergency event. During disasters or public health emergencies, as well as a range of emergency situations, the normal processes that help ensure an individual's continuity of care often get disrupted, and alternative care facilities would need access to a patient's health information to provide safe and timely care. In these situations, individuals may be unable to communicate or share information about their own health history. Therefore, it's essential for the authorized disaster health care personnel, providers, and first responders to be able to access an individual's basic health history such as information on allergies, current meds, and problems to provide appropriate care. ONC certainly recognizes the importance of addressing this gap, and we've been working for a number of years to address this challenge since 2014. We work in partnership with different federal agencies, state and local governments, and work together to make PULSE, for the Patient Unified Lookup System for Emergencies, a reality. In 2020, ONC officially launched the PULSE community, which is a set of software and implementation resources available to state, local, and tribal governments and their partners to implement and effectively deploy PULSE. That code enables users to deploy PULSE during emergencies in order to authenticate authorized personnel to enable them to access health information across health information networks. PULSE leverages nationwide exchange mechanisms that bring together information across disparate health information networks, and that reduces the number of connections for those using PULSE on the ground, which could be critical in these kinds of situations. PULSE can also be designed to partner with state and local health information exchanges to enable authorized and credentialed emergency personnel to access the health information they need to provide care. The PULSE initiative has been underway for several years, as I pointed out, and we want to take this time to reflect on what's working and what's not. We want to better understand your needs and how PULSE fits in your emergency services landscape. We also hope to get your insights on current usage, cost considerations, technical requirements, and the sustainability of PULSE going forward. And for those of you who are new to PULSE altogether, we want to take the opportunity to raise awareness about PULSE and to explore opportunities for usage in your locality. So thank you again for joining, and we really look forward to engaging with you over the course of today's workshop, and really welcome your feedback and recommendations. So let me turn it back now to whoever I'm turning it back to. Thank you.
Thanks so much. Thanks so much, Mickey. We really appreciate your comments and are really excited about today's session. So before we really jump in, a quick review of the workshop objectives. So kind of reiterating much of what Mickey just said and emphasizing, the idea that we want to raise awareness on today's call for PULSE Initiative and PULSE Community, really have those discussions on state and local planning and implementation considerations, get into breakout groups later on in the workshop to have those smaller group peer-to-peer discussions to identify those challenges, those opportunities and considerations, talk about the future of PULSE Initiative, PULSE Community, and broader opportunities for improving access to health information during disasters and emergencies. And we will be doing a deeper dive on PULSE Initiative and PULSE Community shortly. But before we get there, just wanted to provide some context for those who are less familiar. So just to reiterate, for anyone who missed, PULSE stands for the Patient Unified Lookup System for Emergencies. There is an initiative that ONC stood up in collaboration with other federal partners, really designed to support national resilience to access health information during disasters, emergencies, public health emergencies. And then PULSE Community is a technical solution that is a code-based solution that ONC manages and makes accessible at makes available at no cost to states, territories, local, tribal government, and their partners. Okay, so I'm going to hand it over to Kate Kiefer to talk more about the emergency management landscape.
Great. Thank you, Chrissy, and thank you, Mickey, for the opening. And thank you, everyone, for coming. We wanted to just level set and give some foundational information around emergency services and disaster management. With PULSE, PULSE was designed to support disaster management, but we want to make sure that folks who are joining this conversation might be from public health, might be from Medicaid, or might be from different state and localities. So we just wanted to give some level setting of different activities around accessing health information for different emergencies. So this screen just going to points to, next slide, please, the what emergency services are in disaster management. So emergency management being the analysis, planning, decision-making, and assignment of available resources to prevent, prepare, mitigate, or respond to or recover from effects of all hazards. So when we talk about emergency services, that is the day-to-day activities for fire or police departments, any activities that might be trying to respond to a specific emergency, but this is part of the daily routine around supporting a community community and other types of different day-to-day needs. Where disaster management, when this is where Pulse is currently focused right now, refers to situations and occasions that are maybe some different social needs aren't met for during this particular event, or there's a big disruption into the community based on these different disaster types. Next slide, please. So the majority of this conversation with Pulse's history will focus into that disaster area. So these are different types of disaster types, and some might be, just to give some context, around human caused. Maybe there's terrorism or explosive explosions, or natural ones, maybe an avalanche or drought, or maybe a hurricane that might have some widespread geographical impact and reasons to access different emergency sites, maybe a tornado or a wildfire. And there's also technological ones. There might be some hazardous or material release, or maybe even infrastructure failure. But there's different types of ways to address and respond to these different disasters. And the health and medical is an important part to understanding that. And in order to respond to the health and medical of the community, it's important to have access to health information during these different types of disasters. Next slide, please. So at a federal level, for national preparedness and response to these different disasters, there's many different agencies that deal with different parts of it. There's ASPR, the Assistant Secretary for Preparedness and Response, Centers for Disease Control and Prevention, as well as FEMA to help support these things. And there are national preparedness goals, which you can see on the screen. There's also national preparedness systems, and there's multiple parts of the national preparedness systems that we will go into a little bit more in just a second. But this is to show that there are multiple agencies at the federal level that are coordinating to help support the states and localities when they are dealing with and responding to different disasters. Next slide, please. So these are some of the different frameworks. There's for the preparedness and planning frameworks around prevention and protection, mitigation, response, and recovery. And with these different frameworks, there are different roles and responsibilities and opportunities for these federal agencies to help respond and support to these different emergencies and disasters. And of course, many of you are in the disaster space and emergency management, and you probably could correct me in 100 different ways, but this is just an opportunity to lay the groundwork of showing that there's lots of different players and coordinated agencies that help support during emergencies and disasters. Next slide, please. So for the emergency management life cycle, and there are kind of a rotating cycle of these different things around mitigation and preparedness, response, and recovering. So these deal with how do you prevent future emergencies or minimizing their different effects. And this includes activities around reducing chances for emergencies to happen, or mitigation plans to help reduce the risk of these activities. And preparedness, this is how are you preparing to handle an emergency, including plans or preparations, or stocking food, or what are types of activities so you can prepare in the event that an emergency does happen. And for recovery response is what are the actions that are being taken to save lives or prevent future property damage, or provide the different shelters for people who might have to evacuate their homes, whether it's weather event or environmental situation. But the response activities happen during an emergency. And then the recovery process is important to understand the actions to return to normal or to a safer situation following this emergency. And the recovery also includes a lot of the administrative steps around financial assistance, but the recovery activities take place after that emergency. Next slide, please. This slide speaks to that within emergencies and disaster management, there's a lot of time, it's really important to have these partnerships, especially when you are thinking about the health and medical aspect and really accessing the health information during different type of disasters. And this might be your hospitals, your emergency management organizations, your emergency management services, as well as your public health departments. And there's also the partnerships with the like hospitals and blood banks and federal healthcare care, outpatient care, emergency management, public health. So it's just really important to understand where there are those different partnerships within the community and how do you leverage those activities. And I think that Pulse, when we get into some of the different details and how the states have, a couple of states have actually implemented Pulse, it really goes to show, and they have some examples of how they did have to partner with different groups in the community, and understanding those partnerships help improve that access to the health information to help with triaging and treating of different people. Next slide, please. All right, and this is just a very simplified version to show that, you know, every disaster is local, that state and local partnerships are really imperative in addressing disasters, and Pulse can be a flexible way in how it's rolled out and implemented to help support at the point of care or the point of triage for any evacuated or people that are in that disaster situation. So there's a lot of coordination at a local level. There's also coordination with state officials and emergency operations centers. And then there's also the federal level that can help support that local response to those different disasters. And of course, there's always the private sector partners that are also able to help with any of the partnerships within the community to help support that local response effort. Great. And next slide, please. This one also speaks to, because there are different frameworks, and I know that these are at a high level, but there's also a really important thing we wanted to point out within the CDC's readiness, that there, with CDC's public health emergency response and readiness, there's a certain capability, number 6, around information sharing, and that includes information around increasing alignment to different national surveillance activities. There's also, they also emphasize implementing data security and cybersecurity protocols, and they also promote using electronic health record technologies, and information sharing is really important to decrease that reporting time and increase the collaboration across the electronic information systems. So the point of kind of adding in that, whether it's FEMA or ASPR or CDC or what's happening at the local level, the understanding that there's electronic health information that can be available to help support the medical professionals in those response times is going to be really important to have effective response to really improve the localities and states' approaches to these things. And with that overview, I'm going to go ahead and pass it over to Rachel and to go through the Pulse Initiative overview, and she can also add anything I might have missed or perhaps corrected anything I got wrong, but this will start to go into more of the Pulse activities. Oh, great. Rachel, we can't hear you. Oh, there you are.
Yeah, sorry, double muted, of course. So just wanted to say thank you all so much for participating in today's listening session and workshop. We're super excited that you all are here, especially those from the states. We know that you all are very busy these days, particularly around the continued work with COVID and your other disaster response efforts. So thank you all so much for taking the time to be with us today and contribute your lessons learned and your overall thoughts in regards to moving forward. And I do notice that we have a question or so in the chat, and I think what we're going to do is we're going to pause at the end of the next presentation. We'll take some questions there if it's all right with you all. So moving on to the next slide. Great, thank you. So I just wanted to kind of frame, like, what do we know, right? So we know that EHRs by hospitals and physicians are on the uptick. There's major adoption, widespread in regards to electronic health records. So that's a plus. Healthcare providers and first responders who often work at like these alternative care sites, such as shelters, some of them are volunteers and they may not have access to electronic health record systems on a day-to-day basis, but are credentialed and authorized, to use provide care during a disaster, whether they went through some sort of training or system within the state or locality. It's important to note that. We know that many people will seek care outside of their traditional healthcare environments. They won't be able to go to their PCPs. They have to, be evacuated to a shelter or to some other place just for a period of time. And so that continuity of care is broken during that time. And then we understand that providers and first responders, serving disaster patients need basic information such as allergies, current medications and problems. And providers can't rely necessarily on that patient's knowledge in times of extreme stress. I know this from personal experience and working at many shelters during disasters. I particularly remember one where we had to evacuate a community that English was not their primary language. And so, and they were mostly elderly populations, and they showed up at a shelter, and, it was very hard trying to figure out like what medication they were on and whether or not they even had the medications with them, things like that. So I just think it's really critical to have, these first responders and disaster volunteers have access to this information so that they're able to treat patients at these environments. So next slide, please. So what is exactly PULSE? So PULSE has morphed or has evolved over time. And what we currently see is that there's a PULSE initiative, and it's an overall effort to support national resilience through access to health information during disasters, including public health emergencies. It's more of a framework, and it often uses a use case and to specifically for first responders and those credentialed in the community to have access to this information. But it's not just the technology, there are other pieces to it, and Rim will talk in more depth about that, but it's things like policy issues need to be addressed, sustainability and funding types of things, operational kinds of aspects of it as well. So we really see it as not just the technology, but all these other kind of components that are needed to make it successful. PULSE provides the unique and kind of exciting thing about PULSE is that it provides states with autonomy over activation, which helps ensure privacy and security, while allowing connections statewide into a national network when necessary. So, that's the uniqueness of PULSE, is that each state can kind of build it to what their policy issues are or what their current environment is. And so it's not just a plug and play kind of thing. It's a very intensive time in regards to trying to figure things out as to, so that not every PULSE initiative in every state or community is necessarily the same. It's all building towards the same effort and towards the same goal, but it may differ from state or community. And then lastly, we really want PULSE to be able to leverage, current existing state systems, such as the Emergency System for Advanced Registration of Volunteer Health Professionals, or ESAR-VIP, which is, organized and housed in the Assistant Secretary for Preparedness and Response through ASPR. And so we don't duplicate efforts where needed. Some states also might want to work really closely with their state health information exchange to possibly stand up a PULSE system that way as well. So we're really leveraging things that are already in place. Next slide, please. So I'm sure you're thinking, or you're, trying to understand. So exactly like, how does Pulse work? So first off, we have to authenticate the people who are going to have access to this Pulse web portal. And again, the ESAR VIP system, some states may want to choose to use that system, some may not. It just depends on how it's structured in that state or locality. But there might be other credentialing systems that you all use for your professional development of folks. So, there might be some flexibility in trying to build that piece in. But first, we need to make sure that the people who have access are authenticated. And then next, we then allow these authorized personnel just basically can enter a search. So you just enter basic information like the person's first name and last name and date of birth. And then it sends a query across all of these, connected providers and national networks to see if they have any information on this patient. If they do, which we hope they do, they could then send it back to the provider inquiring for this information, and then they're able to view that patient record and then treat them on the scene. Be able to look at medication history or their current problem list. So I think it's really super helpful in regards to getting real-time information on this patient. So next slide, please. So I'm just going to briefly talk about Pulse Community, and Rim will go into more details in the next session about Pulse Community. So ONC launched a code-only technical solution, that we've called Pulse Community. And it enables first responders and other response personnel, depending upon your state's, what your state decides who should have access to this information. But it can be people like emergency medical services, it could be healthcare volunteers, as I've stated before, or it could be epidemiologists if they need additional information on patients. It all depends on how Pulse is set up in the state. And then through this whole process, we were able to develop through this collaborative project. ONC collaborated with the Sequoia Project and Audacious Inquiry to develop just a code-only solution. It's not a commercial version of Pulse, but we wanted it to be available for free to any sort of state or locality or tribal or territorial government and their public and private sector partners to have access to this, to be able to begin building their own version if interested. It allows the flexibility, to build on existing health information exchange infrastructure, as we shared before. It's non-proprietary, which is good, and things like that. But it does have its limitations, and Rim's going to talk a little bit about those limitations in the next section. I also did want to say that there is one vendor that's implemented a solution based on the Pulse Community Code as of today, and so you'll hear the 3 states today talk more in depth about their use of that version of Pulse. Next slide, please. So I just wanted to briefly show you a sample workflow of how Pulse works in the just a sampling of it. Again, it may vary by state, just depending upon the health information exchange infrastructure that's already in place, whether or not they use some sort of ESAR VIP system or not. Things like that, and the types and numbers of alternative care facilities as well. So next slide. This is just a basic Pulse Initiative timeline. This is kind of where we started back in 2014 with just some bare bones funding from the HHS Ventures project, all the way to today where, you know, we're beginning to look and evaluate Pulse Community to make it better and to make it more accessible and usable by states and communities. Next slide, please. So here we are today in 2022, and we are working in partnership with EMI, and we will be, you know, EMI is going to conduct a comprehensive technical evaluation of Pulse. And I think this is important because this is where you all can provide us some feedback. Currently, Pulse Community has a gateway in the sense that you have to request permission from ONC to use Pulse Community and have access to the code. However, you know, we'd like to know from you, does it make more sense to put it out into the traditional open source community and let it expand from there? So we'd love to hear your thoughts on things like that. And so through this facilitated workshop, you know, we want to better understand from you all how we can make Pulse Community better in regards to the usability, how any sort of implementation flaws or challenges that you might see, and what resources you think are necessary at the local and state levels. And then lastly, we're going to hopefully develop, EMI is going to develop a written independent assessment of the findings, which will include of today's convening, a summary of some of the technical evaluation pieces, and then provide some next steps as to how we might overcome some of the challenges that you all help us identify. And next slide. With that, I'm going to hand it over to Rim, who's going to go into more of a deep dive on Pulse Community.
Great, thank you, Rachel. Can people hear me all right?
Yes.
Sure can.
Thank you. And I'm Rim Cothran. I want to advisors, and I want to add my thanks to everybody that is talking a little bit more about technical solution that Rachel introduced. And then after this discussion, we will pause for a few questions. I see that some people have been dropping some questions into chat, so we will come to those after this section. Let's move on to the next slide, please. First of all, let's touch just very briefly on what Pulse Community is and what it provides. It's really intended to allow healthcare professionals that have been credentialed to access health information to get that access during critical health emergencies when they are not located at traditional care settings, such as in shelters or other alternate care facilities. It is meant to retrieve information that may exist on those individuals to help deliver critical care, but it is not a documentation system. It is not a place where you can record the care that is actually delivered. So it is strictly for retrieving health information that may exist on people that are located in these alternative care facilities. It does provide a number of very critical functions. Some of those functions are administrative, such as activation of events, user management, and management of the alternate care facilities that may be locations where Pulse is being used. It also includes security functions such as full audit logging of everyone that has accessed health information, access controls for users and full user controls, and also provides a capability of single sign-on with ESAR VIP systems if a state has stood up an ESAR VIP system and wishes to use it as a means for providing access to Pulse. And then finally, it provides a mechanism to securely query for and retrieve health information from individuals. And as Rachel said, that is accomplished by searching for a patient, a victim, or evacuee that may be located at an ACF to see if they have information on the network, retrieving that information, and then examining it to deliver care. Now, it uses national standards to do this. That includes for SSO, SAML2 standards, and for the query and response mechanisms, it uses the standards that are widely adopted and managed by the eHealth Exchange, including patient discovery, which is based on the IHE profile for cross-community patient discovery, query for documents, and retrieve documents. If people are not speaking, if they can put their connections on mute, that'd be helpful. Thanks. Query for documents and retrieve documents that are based on the IHE profiles for cross-community access, and clinical documents that are part of the HL7 standard for documents. Importantly, it is intended to leverage existing infrastructure, and so that may mean the HIEs that already exist within the state or eHealth Exchange through the use of national standards that have been widely adopted, and makes it well positioned for potential use of TEFCA and future infrastructures as well. Let's move on to the next slide, please. There are a number of use cases that you can imagine for Pulse. It's been proposed for day-to-day emergencies to provide access to health information for EMS responders or other first responders that may not have access to health records. It has been used in disaster scenarios to address the health needs of victims or evacuees that have lost access to their homes or their traditional healthcare settings. Those uses include, for example, wildfires and storms, some of which you saw on the timeline that Rachel talked about earlier. And it's also been used for COVID-19 when traditional healthcare facilities and the healthcare infrastructure has been overwhelmed and alternative care facilities needed to be stood up and needed access to critical health information. Just go on to the next slide, please. So the question here is, if you're interested in Pulse, how do you get it? Well, first of all, it's available through ONC, and there's an email address here that you can access to request Pulse. It includes the source code and an implementation guide that are all available upon request to ONC. It's really intended for use by state, territorial, local, and tribal governments and their public and or private sector partners that might include vendors that are working with them. There are a number of different considerations that you need to think about and work through in order to effectively use Pulse. It includes planning, implementation, and the use itself. And it'll be necessary to think about these topics even if you're engaging with a vendor to implement Pulse Community for your use. And we will touch on each of these different areas here briefly. Let's go on to the next slide, please. As I said, we'll touch on all of these different considerations that are necessary to think about in order to effectively use Pulse. Next slide, please. The first one is to really think about governance and leadership. It's going to be important to engage leadership of all areas of government. Pulse is made available through the federal government, but it will be used at the local, either state or regional government level. And there's a need to address leadership and collaboration and coordination across all of those levels. It'll be important to coordinate with local industry partners and contractors, as well as the local healthcare community in making health information available and ensuring that they're engaged. Need to consider the entire all hazards preparedness and response ecosystem. Includes whatever is in place within the state today for emergency or disaster response and preparedness, and all of the mechanisms that may be in place within the state or be developing within the state to address those emergencies. And it's important not only to identify and engage collaborators here, but also to identify champions at state and local levels that can promote the use of Pulse and engagement in Pulse as a solution. Let's go on to the next slide, please. Second, it's really important to consider and align with policy that includes the policy associated with public health efforts. Many of Pulse's potential uses touch on public health use cases and oversight. And it'll be important also to leverage federal partners such as ASPR that also provide systems and guidance such as the Empower program to address the needs during emergencies or disasters. It'll be important to consider policies on how Pulse can be authorized and activated, such as through the state emergency declaration process or other means to make access to Pulse available. It's also going to be important to consider policies necessary to embed Pulse into emergency and disaster response operations. It can't live just as an island, but needs to be fully incorporated in the process for addressing the response to health emergencies. Importantly, we must think about how Pulse can meet or complement critical state objectives and regulatory considerations or policy levers as necessary. There may be needs for policy specifically to address regulatory barriers or to enable effective use of Pulse. Let's go on to the next slide, please. Third here is partnerships. It's really important to understand and leverage partnerships at all levels. Need to think about who needs to be involved to make emergency and disaster response successful. And I'd encourage you to think about the potential partners that are listed on the slide here, but also think yourself about who in your own state, your own community, your own environment, your own ecosystem that would need to be engaged. Let's move on to the next slide, please. This is a little bit on technical and network implementation considerations. There are a lot of words on this slide, and I'm not going to read them all. And this may not be all inclusive. Pulse is a technical solution as a code-only solution that's made available to the state. And it's important to really consider all of the technical considerations in deploying Pulse. It is a low-cost solution, but it's not a zero cost. We'll get more on what we might need to consider on funding and sustainability in a minute. It is intended to be scalable to address large-scale disasters and deployments that might be statewide. It is designed to be secure and designed to be deployed in secured cloud environments. It is designed to be extensible to meet the special needs of a particular environment in which it's deployed. So if a state has specific needs or specific use cases, Pulse can be extended to address those. It is generally simple to use because it follows a common HIE model, and that is I search for a patient, I request health information on that patient, and I view that health information. But there is still a need for training on the system as well. And it can leverage existing infrastructure, and this is really important, whether that be local HIEs within the state or the eHealth exchange or future networks and initiatives that are on the horizon. And importantly, it will be necessary for a state or local government to identify the IT resources necessary to deploy, configure, and operate Pulse, as Pulse is not a commercial, Pulse Community is not a commercial solution, but it's a code-only solution. Let's move on to the next slide, please. Training and support, I touched on this very quickly. While Pulse is simple to use, it does require training to use it effectively. You might consider planning drills or exercises to train staff in effective use of Pulse. You might consider structured training that is periodic to keep potential users up to speed. You might consider just-in-time training as appropriate, really to the anticipated users that you believe in your particular environment are the users of Pulse. Remember that users will vary state to state or implementation to implementation, and might include state staff, might include IT resources, and likely include volunteer health professionals, all of which need to be trained in the proper and effective use of Pulse. Finally, training resources are available for Pulse, so there are materials for you to base things on. Let's go on to the next slide, please. It is necessary to really consider costs in both standing up and operating Pulse. And I would emphasize that this includes planning and deployment costs and implementation costs, but don't overlook the costs, the ongoing costs that need to be considered in operating Pulse. The recurring costs for just standing it up and hosting it, but also to continue to advance new use cases that are important to the state, adjust to changes in standards and workflows that are important to bring in, and to keep connections to the infrastructure that you're leveraging as sources of health information fresh and operational. Next slide, please. And we'll touch just very briefly on operations and management. Need to consider that Pulse Community is currently a code base, but it's taken from a snapshot in time. And therefore, it will be necessary to not only manage and maintain the running instance of Pulse, but as I said, it'll be necessary to update it to address emerging standards should they become widespread in the environment in which it's deployed. Practices in the exchange of health information and access to health information, and use cases that may introduce new workflows, new sources of information, and new uses of users or alternate care scenarios that you might imagine. Let's go on to the next slide, please. Now, we talked about everything in this circle diagram here in the middle, from governance and leadership through operations and maintenance, but it's important to remember that all through this, there's a need for appropriate resources that includes resources to coordinate the partners that are involved in deploying, operating, and using Pulse, the technical resources that are necessary to stand it up and operate it and keep it fresh, and the operational support to support users in their use of Pulse and training for Pulse. It's also really important to communicate about Pulse, to understand and communicate the value proposition of the access to health information in emergency or disaster scenarios, to talk about case study examples of where Pulse and access to health information in emergency scenarios has been effective, and we'll talk about some of those in our next section. Promotional materials to help people get excited about the use of Pulse and access to health information so that during emergencies and disaster, that information is available. And then just general outreach and communication to partners so that they know what the status of Pulse is, how it's being used, any barriers, and success stories. Let's go on to the next slide, please. And now we have a little time in our agenda that we can pause and talk a little bit about questions that you folks might have that we might be able to start to address. What I'd suggest is you can either put questions in chat, and there have been a few questions that have been in chat already, or feel free to raise your hand and we can call on you and you can talk about your questions or address your questions verbally. To kind of get things started off, I did see a couple of questions go by that I'll try to call out. First, Chris Baumgartner asked how Pulse might leverage TEFCA. I touched on that very briefly, that it is making use of widespread national standards for query and response that are very similar to those that are part of the QHIN technical framework, and therefore it's well positioned to leverage TEFCA. I don't know if Rachel, you want to add any of your thoughts about how Pulse and TEFCA might get along.
Yeah. I think it's a really interesting use case. I do think, though, Pulse as it is today, it's really designed for treatment purposes. And so I think we haven't done a lot of work in regards to trying to see how it could play in regards to the public health use case, in regards to, public health agencies getting additional information. But I think it's there. I mean, the infrastructure's there. It's just, I think that it's looking at those local and state policies and making sure that they align with how to implement it in that location. So yeah, that's a great idea. Thank you.
Thanks. David Harden also dropped a question to chat. How does Pulse work with respect to states' health information exchange, and specifically if patients opt out of the HIE participation? I can at least get us started there. The standards that are being used here to access health information send a query into an organization that might include a state's health information exchange if it supports those national standards. But it is going to be incumbent upon that organization to make decisions about whether a disclosure is allowed either under local law, federal law, or the policies associated with the HIE. So it would be upon the HIE to make a decision on whether to disclose information based on a patient's opt-in or opt-out status and local law. David, I don't know if you have any other questions or would like to expand on that. Feel free to come off mute and voice them if you would.
Yes, I just had two other questions. They'll pretty much have to deal with confidentiality. For example, if the ONC has reference materials that an interested agency's legal counsel could review to make sure they're complying with Hipaa Part 42 CFR requirements to preserve individual patients' confidentiality and to keep the agency from any type of legal jeopardy. And then the last question kind of related to that is, in the absence of a unique identifier such as a social security number, does Pulse rely upon probabilistic linkages to identify the patient of interest?
Well, I will touch very briefly on the second question. The answer to that is yes, in general it does. It's using traditional demographic information about the victim or evacuee to do a search for an existing patient in external systems. That is based on at least name, birth date, and gender, and optionally address, phone number, and social security number if they are available. But it is a probabilistic matching search. Rachel, I don't know if you have anything to say about reference materials on Hipaa, et cetera.
Yeah, so ONC does have some specific reference material on its website in general around, HIPAA and 42 CFR. However, we don't have anything specific for Pulse and that use. Currently, as I stated before, Pulse is using the treatment, is primarily used for treatment at this time. That's how it's been utilized. It hasn't been utilized in like the public health case or any other use. So, but that's a great suggestion. I think we'll definitely take that under consideration to see if we could develop some material specific for Pulse around those issues.
Are there other questions? I see one from Travis. Travis, did you want to come off mute and put words to your question there?
Yeah, I mean, it could be just because I'm in the COVID state of mind, which I'm sure we all have been for about 2 years, and working specifically on vaccine administration. And the immediate thing that jumps to mind is having that patient's record on hand if they're unsure about their contraindications status for receiving, say, a vaccine or an antibiotic during an emergency situation. So I just didn't know, have you guys looked at that at all in terms of how Pulse could be assisting in dispensing activities, and if it could, I'm not extremely technologically savvy, but as an open source code or a code, could it be integrated into the design of a platform so that we wouldn't have to have people jumping in and out of different platforms to say, check someone's allergic status to amoxicillin or ciprofloxacin if we were giving that in terms of an anthrax attack or something like that, that they don't know, and we want to get them that countermeasure to prevent illness. So I just didn't know if you guys had looked at that at all, and if so, what kind of things had come up.
I think it's really good and important to be thinking about use cases that might make sense outside of what we think of as traditional disaster cases, but including those like public health emergencies that you're talking to. I know that California has deployed Pulse to use in the current public health emergency associated with COVID. Maybe during the state session, we can touch a bit on their experience. Leslie just dropped in the chat that she's happy to talk about that when she presents then. So Travis, I would recommend that you, if you can, hang around for the next section of the presentation when we talk about state experiences. Maybe Leslie can help you answer your questions.
Lou, thank you.
I don't see anything else in chat. Are there other questions people have at this time?
Big Rim, there's a couple. Is there a version of Pulse that can be used to train students and fellows in academic settings? I at this time I can say probably not, but I don't know if any of the states today, they might have anything to contribute around that, to see if they've used it in regards to training. I don't know. And then we had another question around, are the appropriate uses of Pulse situation up to states to decide? Yes. Yeah, that's what we're saying, is that, we wanted to build it flexible enough so that there are possibilities for you all to utilize it above and beyond what it's currently being used for, but also recognize that there will have to be some work on your side to work through those policy issues in order to implement it appropriately. I don't know, Rim, if you have any thoughts on that either.
I don't really have much of anything to add, Rachel. I think that that is the way to be thinking about it, is to think constructively about how it may meet some of the needs that you have within the states. And I think that that's one of the reasons that we asked the 3 states to come here and present with us today, so that you could get their experience and see some of the unique ways that they've found to use Pulse themselves. Are there any other questions?
Not a question. This is Dave. With Wilfred's question about a training version for Pulse, I think that's a great idea for lots of reasons. One is you can use that during drill training and also help you identify scenarios to help work out the bugs for Pulse and develop a future feature. So I thought that was a great idea. Just wanted my hats off to that question.
Thanks, David. Any other questions or comments? If not, then I'll turn things over to Kate for our next discussion. Thanks.
Great. Fantastic. Thanks for the questions, the thoughtful questions. I think you guys are thinking about a lot of different ways to potentially apply Pulse within your states. So we're going to go ahead and go over to the state panel, where 3 states have implemented Pulse. And I want to introduce our speakers today. Today we're going to have, excuse me, Leslie Wittenrood, Chief of the Office of Health Information Exchange for the State of California Emergency Medical Services Authority. We're also going to have Jamie Bustos, the Acting Bureau Chief for Florida's Center for Health Information Technology and Transparency. And from Texas, we're going to have George Gooch, CEO of Texas Health Services Authority, and Steve Eichner, the Health Information Technology Lead from Texas Department of State Health Services, and Nora Belcher, the Executive Director for Texas eHealth Alliance. I'm going to go ahead and next slide, please. And Leslie, if you're available, we'll go ahead and let you speak.
Hi, thank you. This is great. It's been so long since been able to connect to a national work group meeting like this. We've been so focused on the pandemic the last 2 years and utilizing Pulse within that pandemic. So let me tell you a little bit about California. I'm going to go ahead and have you advance to the next slide for me. Great. So kind of the history of Pulse. We had the pleasure and the privilege to kind of launch this with ONC and be the first state to work in the development, working with our health information organizations, with the ONC, with ASPRs, with our HIOs in California. Could we build this all together? Could we make this work? How could we connect it? Also with our DHV system, our ESER VIP system, to have our providers do this. So just as we were able to coalesce, do tabletop drills, get this to work, getting ready to roll it out, and California Emergency Medical Services Authority, we're in a unique position. We're a state agency, we're under Health and Human Services for the state of California. But in addition to that, we also have CalMap providers, which are emergency medical providers, licensed providers in the state of California that we send out to alternative care sites. So it's our own employees, in addition to MRCs, as well as disaster healthcare volunteers that we work with on a continual basis to provide medical care in our facilities that we set up in these disparate conditions when a declared disaster occurs in California. So that really helped us propel things forward. Not even with enough time to be able to get past our tabletop drill, get some of the trainings done for our medical providers, did we start in with the wildfires, one right after another. Unfortunately, we've learned, the term when there's a disaster, you need to write it, which was very helpful because we're in real world. We're able to see right away. And with our end users, what was working, what wasn't working. We also saw the need. We needed to add all of our health information organizations in the state. We had started with 4 to pilot this just to see if we could get the connections to work and what was needed. So we found out a lot of things real quick and started pretty fast and heavy with utilization and utilizing this. The first time, really, I would say, that we were able to use it and implement it and really train people was when we had the wildfires in Paradise, as you all heard about, where the whole town burnt down. And that was in 2008. But you'll see in 2017 and 2018, we had a lot of we were going to start this, try to use it. We weren't having enough records. We saw that need to expand to national networks and add additional local HIOs. And we've added 13 in the state of California. I'm going to go ahead and have you go on to my next slide. So, with that being said, of where we were at with this, we got to a point where we added in on the local health information networks. We started using it and drilling this in between disasters. And we started doing a fast pace of our disaster healthcare volunteers, along with our CalMap teams, of doing trainings on the system and kind of train the trainers during all of our wildfires. So when we got to the point with kind of pulse administration. We went out and did procurement. We worked with audacious inquiry, and we moved on to the enterprise. We looked at community. One of the things with community, what was happening is in 2020, right out, matter of fact, at the ONC meeting, everything was starting to break with repatriation of some of the State Department employees coming back actually into California from China. And so from there, everything just fast paced. And we had at the time our CalMap members, I would say in our database, medical providers, probably about 200. We now have over 3,000. And then in addition to that, when things got really bad in the state and we needed more medical providers, we started what we call Health Corp. And so to date, we have about 20,000 medical licensed providers in the state of California we've been using throughout this whole pandemic. In addition to that, we not only use them in alternate care facilities that IMSA has oversight, or if the county has stood up and they're needing assistance as our medical teams as an asset that we provide. We also have helped provide staff for the shortages during the surge in the hospitals as well. So we really needed that help at the time, internally and externally, to go ahead and go on to enterprise and have the assistance of having a vendor be able to take care of a lot of things for us. We have training manuals that we had created, training scenarios that we've done over the years that we've shared with many of our other state partners and the ONC. We still have those and utilize those, but we really needed that extra set of hands because my staff also deploys and does care within the field during that time. So that's how we ended up moving on to enterprise. And it's pretty recent that we have done that. That occurred in September of this year that we went ahead, onboarded. It also gave us the expansion of medical records because of eHealth Exchange as well. So we wanted to really have that bandwidth to be able to have that coverage for the entire state, which had opened up additional patient records for patients who may be visiting in California as well and not residents here. Next. So again, I went over the use case. So this is the real moment of truth, I say, of when we developed it. As you see in the bottom of that slide, that's me. And I'm actually training right there in a shelter at a high school gym to our medical teams right there, how you go through and utilize Pulse. I've been very fortunate. The state of California has allowed me to use my team and also borrow some of our disaster medical teams to be able to go out in the field and kind of launch these ad hoc trainings and deployments at the shelters for providers why it's occurring. And that's been very vital in the use. I see what was a question just came up and I'll just stop and answer it. Why did we make that transition to move to Pulse Enterprise? A couple of things. We did not have the staff or the bandwidth to be able to use the open source without having a vendor. In addition, we have that desire to move onto eHealth Exchange, also be able to get records from Commonwealth, and then also to be able to onboard to SureScripts. So we went with a vendor that could provide us that at the time. So as you can see, you know, we had 85 facilities, the number of people that were evacuated. We ended up searching 326 patients. One of the things that was really valuable, I'll tell you hands-on in the fires, were the medications, knowing what patients had medications. So for instance, these evacuees were sent to Chico, about 40 miles from the town of Paradise, and the entire town burnt. So we had CVS that burnt, and for some reason, the CVS locally in Chico, 40 miles away, wasn't able to pull up patients' records. And because they left so fast, they may have only had insulin that was in their purse for a day. We did a lot of scripts using polls to be able to verify that people currently were on medications. Immunizations actually were something, I know that question came up, I said I would respond. The value of that really came up in our training and drills. I found the medical teams, when they were doing triage, that was one of the #1 things that they would look at first and foremost in the record, was what type of immunizations. Especially a lot of our scenarios previously had always been earthquake, and that's, knock on wood, not going to happen right now, but that's what we always thought we would be using this for in California. Our use case would be to respond to an earthquake, which was logical for us. And it really became wildfires that this has been utilized up until the pandemic. And that's just expanded our need. And we've been able to use Pulse in ways we never thought we would ever utilize it. So I'm gonna have you move to the next slide for me. So here you can see these are some of, our deployments, the different activations. So during the pandemic, you can see we set up shelters. Some were used, some were not, just in case we had big flows. The one that you see actually over to the right with the portable medical shelters, those actually did not hold patients. Those held all of our medical teams, the hot teams, and also the logistic teams. If you see, sorry, I should have provided a little bit better picture. That is actually a part of a building, and that's a Holiday Inn. The state of California took over and purchased multiples. That's right by San Francisco Airport. That wasn't operating as basically a care center the whole time during the pandemic. It's on warm right now, but we were doing care of patients that went beyond even hospital care. So when the hospitals hit surge, we actually even opened up 3 hospitals that used to house patients that recently had been shut down, that we reopened those hospitals and we staffed those hospitals, taking patients from all over the state. So one of the things that's really changed with COVID and the pandemic response, we had a PCR that was maybe a page to 2 pages on paper. And now, because of the amount of care and the type of care that we've provided for a patient on vents, we have our own ICUs as well as lower level of care when that wasn't available in a hospital setting for the patient. Some of our PCRs have now reached over 100 pages and paper. Then we had to deal with the whole situation of hot zone and non-hot zone, and having that information available outside of the hot zone. We also utilize Pulse on intake. Was this a patient that could be served by one of our centers before they were transported, or a county was asking us, or a hospital, to take on this patient? So that was used quite a bit on intake as well. So like I said, it has expanded upon any imaginable need what I thought Pulse could be utilized for. Also, our need has expanded in the system. We need a system that can actually document the care, that we can track the transition of care, that we can do discharge summaries in as well, that this information can then also be documented and go back to our health information organizations to update the patient's continuity of care document. So those are some of our current needs that we're looking at addressing, beyond what Pulse can provide at this time. Next. So that kind of went into, the lessons learned a little bit of, what our needs are as well. One of the use cases that I didn't mention on the previous slide, and I'll go ahead just real quick because I don't have much time and I don't want to cut into the other states' time, is that we actually right now we have infusion centers in the state of California, several of them, and we have utilized Pulse in those infusion sites for the intake nurse. So physician, somebody who has COVID, they think they're a good candidate to have infusions or have the injections in the site for COVID to help them get over it, to keep them out of the hospital or to keep them off a vent. The physician can go ahead and write a referral to one of our sites. And then the intake nurse is now searching Pulse, looking to see. They were just doing a phone call to the patient. So now this gives them all that medical information up front. What they've had in immunizations, if that's there, what current medications they're on, what was, their last chief complaint, or what their primary medical conditions are prior to picking up the phone, talking to the patient, doing that intake. Then that information is available on site. So real quick, I'm going to go through lesson learned, and I don't have this on here, and I should have had this added. Biggest thing, end user engagement of the people using this is the most important thing. You want to bring them in early on. They're the ones who are going to look at what Pulse can bring up. What's the quickest, most key screen that they're going to need to pull up the information so they could do quick assessments, triage, quick treatment. What's the most important for them? And then, the data, that's another thing we have to work through. Some of our health information organizations on eHealth Exchange, they're very forgiving, where others aren't if you make a mistake. So we always include that in our trainings. We also will throw some, when we have time in a training where we're not in real world, we'll throw in like little things to get them used to. Nope, you have to do this if there's a hyphen or a not or a comma. Reliable connections. That was one of the things too. We had different certificates we were always having to switch out and keep control of and monitored when we were just doing it with one-to-one connections with each of the 13 health information organizations. eHealth Exchange, having them go through eHealth Exchange and onboard that way has definitely helped, and that's helped us with our bandwidth. And then also configuration requirements. For us, we use the disaster healthcare database because it checks our licenses of our providers every 24 hours, including our volunteers. But some of that integration, we continually are having to monitor and really make sure that if somebody's doing one thing on one end of the system for the single sign-on, that it's not affecting Pulse on a different end. So I'm happy also down the road, if we don't have time for all the questions today, you're welcome to reach out to me, independently as well.
Great. Thank you, Leslie. That was very helpful. You've always been an amazing champion for Pulse and really seen it through its infancy and implementation in California. So that was very helpful. I'm going to go ahead and pass it over to Jamie Bustos from the state of Florida for their E+ emergency patient lookup system and their overview of their implementation. Jamie?
Thank you, Kate. Hopefully you can hear me.
Yep, you're good.
Great, thank you. So in Florida, we actually call Pulse the emergency patient lookup system. It goes by E+ here for some historical reasons. Next slide, Kate, please, for whoever's advancing them. Thank you. So why did Florida choose to roll out and implement E+? Initially, I guess people think Florida, the first thing you're going to think is hurricane. And then just some quick little short facts. Since 1851, Florida's had 50 major hurricanes that were at a category 3 or higher. A little bit ahead of Texas, who's had 25. We are surrounded by water, and then 6 of the 10 costliest hurricanes in U.S. history have impacted Florida. Knowing the population that has to move during those disasters and seeing how a lot of this planning has to happen days ahead of time, There's a big missing gap there of coordination and getting information that's in real time that would really help with planning. So the ability of being able to go after high-tech funding and having that being available to us was very important in moving forward with this decision as well. The Institute of Healthcare Administration was awarded funding, I think, in 2019. We actually had funding a year before we implemented. It took us that long to really stay engaged, and Leslie hit on a few good points there about, getting engaged with the right end users is key. So for us, we initially wanted to pass this project through an agreement we have with one of our sister agencies, the Florida Department of Health, who has a heavy involvement. They staff the shelters. But COVID hit, there were some setbacks. We'd get ahead in some conversations, and then things would kind of fall off for a little bit. So we were eager to really move forward with this, and realizing that we would have a hand in the path for funding was the reason why we ended up going ahead and executing the agreement ourselves. Being that we're the state Medicaid agency, we have some good agreements in place and good relationships we thought we could leverage later on. So we ended up executing an agreement with Audacious for the enterprise version. Next slide, please. So being that our current role is kind of, if we were to put it in football terms, we're serving as the quarterback. We're kind of administering the system. We're credentialing end users, providing training. We're working with partners and trying to really grow the knowledge and of this space that's out there, and really trying to identify who are the key players that are involved at the beginning and at the onset of these emergencies. Serving in this role gives us a little bit more flexibility. We have many sister agencies that are involved, a lot of county organizations that are also involved when it comes to evacuations and staging or staffing shelters. So for us, it's been helpful serving in that role. Audacious has been providing all the technical solution and support that we need at the onset of everything we've done since the implementation of the system. And the enterprise version also made more sense. The open source version for us, there were a lot of unknowns. We weren't sure what sort of implementation timeline we were looking at. Being that we would have to customize it, we needed to ensure we had plenty of resources at the state level. It was still unknown who this system would live with in Florida at that time. So knowing that there would be proper attention and support of that for the year or two to get that really going was unknown, as well as costs. I think the enterprise version, you kind of get all the bells and whistles. You know what you're getting. You have a set cost that you can work with. You can budget for appropriately. Not having that information made it a difficult kind of path to follow for us. Next slide. Some examples of our activation. So I'm sure many heard the Surfside condo collapse, which occurred last year. This was something where I believe it's a true testament to the flexibility of the system. We learned about this. I remember it was a Thursday evening, and we spent Thursday night just trying to find who was down with boots on the ground at the condo collapse site that we could engage with. That's probably been one of the areas that you need to really focus on, is engaging with the right folks. And this was a new type of disaster we had not really worked with. So the goal there was to try to identify missing individuals at the onset. The search parties were going on, and early counts, I believe there were like 158 missing people. Our thoughts were, if we could get a list of those missing people, run them through the system, we can, since E+ is tied into our encounter notification system, we could then identify folks that may have checked into a different facility or been in the hospital the day before. We thought maybe this could rule out a few folks that is when you're dealing with where minutes matter and hours matter, maybe there would be less people than what they initially thought were there. What we learned through that engagement was that we had to strengthen our relationship with emergency management services as well as law enforcement, because we were dealing with missing people. That was something we hadn't thought about, but going forward, that was somebody we were going to definitely include as we continue engaging with this system. The second activation we did was during Tropical Storm Elsa, which hit on the west coast of Florida. There were some voluntary evacuation orders granted, but it was not as big of a hurricane. By the time we got engaged on the next day, they were already discharging some folks that had evacuated. So I felt like we kind of maybe missed an opportunity there a little bit. Next slide. Some other cases, potential use cases we're doing. And this kind of, from our lessons learned, we started moving forward and finding out Red Cross is a potential partner we're seeking to have. We've had good conversations with them. What we're trying to do with Red Cross is they actually provide training on how to open, manage, and close down a shelter. So our trade out to them basically is going to be to teach them about E+. They're going to train us on the shelter trainings that they have. And not just us, but also we have over 400 staff, field staff that would be around the state. There was a need to, and I think a need to really be successful is to provide the right training, the right education, but also when a disaster hits, folks at these shelters are going to be, they're automatic. They're going to be going through the motions of moving people around, getting them settled in, providing care that they need. It may be hard to work in an electronic system for them to go through when they've been relying on paper or logbooks that they may have. So having the 400 staff ready to go would give us the ability to maybe have somebody on site at an actual shelter walking them through the system. I think that would give us a little bit better chance at staying engaged and really find and show the value of the system. Some other use cases we're looking at is localized flooding. We get that a lot with a lot of rain, especially in low-lying areas. We've been contacted by some folks on the east coast of Florida that were interested in potentially moving their residents for about a week while they did some mold and mildew remediation. They figured if we could move folks out temporarily, they'll be displaced for about a week before we can move them back. This would at least give us a system we could use to track them in real time, and also to have the ability, if we have to transfer them out, to show where they're at in real time. And then another thought was maybe sinkhole impact zones as they come up. Now, those are more dealing with local governments. That's not something we would have a statewide executive order for. But again, I think that's something we're exploring because the system is so versatile in the way it was developed. Next slide. I think I might have touched on some of these already. So the collaboration with law enforcement is key. We also learned that different parties are responsible in different areas, depending on the county. Some have better resources than others. We have, I think, 12 counties that lean on the law enforcement to actually open up their shelters. Home health and sheltering are the most at risk. We're also looking at developing, using some of our interstate data. We do have, I think, 3 states touching Florida. And during evacuation, especially in the Panhandle, you see people leaving to Georgia, Alabama, sometimes west to Louisiana. So collaborating with those partners, and we're happy to see that Louisiana is in some of these discussions, is something that's going to lend itself to be more successful down the road. We also realize that holding the data is easier rather than trying to cross-reference and looking back at later on as maybe some older data sources. I mentioned about having on-site deployment of an E+ trainer per se. That's something we're really going to put efforts into, and staying patient and persistent. We've knocked on many doors many times, and I think at the end of the day, some have opened, some have closed, but they opened up later. But we're still moving forward, and I can share one success we did have was we were able to achieve the Cms certification for the system. So that just that was just another reason for our leadership here at ACA to really support our efforts here in this as we continue to grow E+. I'll pause there, and I think there may have been a question or two that popped in.
Yes, there's a question from Steve Eichner about what strategies are in place for auditing access to records to ensure that all patient queries are appropriate.
Now, that is something we did cover with our vendor, and I'm not sure if Audacious will be having a section to cover during these slides, but that's something I know we have accounted for. In our agreement, we walked through that agreement closely with our general counsel's office. There were some concerns around the auditing piece, around access, around how is that going to be handled, and a lot of things. The one thing I will say, the terms of use is what we're leaning on, and we've incorporated those through reference, because as somebody logs into the system, they have to agree to those before using them. So I know the system does track everybody who comes in, the searches that were done, and we're able to go in ourselves and actually pull some of those reports out when we need to.
Great, fantastic. Thank you for the question in the chat, and thank you, Jamie. That was very helpful. I think Florida has come up with a lot of creative ways to reuse it for different types of emergencies. So it's interesting. Even on the side, I was like, sinkholes. I never thought about sinkholes. So great use of some creative use of Pulse or E+. All right, we're going to pass it over to Texas, and we're going to have George Gooch, Steve Eigner, and Nora Belcher speak to Texas's experience with implementing Pulse.
Thanks so much. Hey, everyone. I'm George Gooch, CEO, THSA. I'll go to Nora and Steve to briefly introduce themselves, and then I can kind of lead us through this, and you guys can add in as we go along.
Yeah, it works in here, but it didn't before. That office is total.
Thank you. My name is Steve Eitner. I'm the Health IT lead for the Texas Department of State Health Services, and I've been working with the THSA to implement Pulse in Texas.
Hi, everyone. I'm Nora Belcher. I'm the Executive Director of the Texas eHealth Alliance. We are a statewide digital health advocacy group, and I worked on Hurricane Katrina. So the work on Pulse is near and dear to my heart because I was there when we didn't have any records for any of the evacuees that we were trying to serve in 2005. And this project is incredibly important to me. So I'm delighted to hand it over to George for the presentation and the layout.
All right, thank you. And with that, we can go to the next slide. So we'll just pretty briefly go through who is the THSA, what do we do, and then we'll talk about the history of Pulse in Texas, the specific use cases that we have, a recent deployment, and lessons learned from that deployment. We can go to the next slide, and even the next one. So I think part of what makes Texas unique, above and beyond all the other ways that Texas is quite unique, is that we have a quasi-governmental organization that is the Texas Health Services Authority, or THSA, that runs state-level health information exchange operations, including Pulse in Texas. So we were created in 2007 by the Texas legislature as a public-private partnership, essentially to run statewide health information exchange services. We do this through two major programs. One is called HIE Texas. That's the actual electronic HIE software platform and each of the programs underneath it, including Pulse. And the second, very different animal, obviously outside of scope for today, it's a Secure Texas. It's a privacy and security certification program, but it is one of the programs that we were required to offer to Texas-based covered entities by statute. We are governed by a 12-member board of directors that is appointed by the Texas governor and confirmed by the Texas Senate. Those members represent patients, doctors, hospitals, health plans, and just about everything in between on the healthcare continuum. And then we also have two ex officio members, one representing the Texas Department of State Health Services, which is where Steve comes from and runs public health within Texas. And then another from the Texas Health and Human Services Commission that helped guide the decision-making of the authority. So, and we can go to the next slide, but I'll just kind of comment on, the uniqueness of THSA and how that plays into Pulse. In Florida, they're run out of the EMS agency with Leslie in, California. In Florida, they're run out of Medicaid, but we're a quasi-governmental organization that is, while we do have authority, we do not have regulatory authority. So we can't make people do all the fun things that we want to, like adopt Pulse. It even heightens the need and builds on some of the comments made earlier by ONC and by REM and EMI advisors regarding the need for cross collaboration between the public and private sectors. We work with healthcare providers, hospitals, local health information exchanges on the private side of the equation. On the public side of the equation, we work with our Department of State Health Services and Public Health Initiatives, our Health and Human Services Commission, and Medicaid. And that's where a lot of the funding to provide for Pulse comes from. Medicaid working with CMS to draw down funds previously for high tech, now under MMIS, that helps support the infrastructure for the Pulse system here in Texas. So THSA is this coordinating entity in the middle of all of this that operates all of these health information exchange services, but it does take a community to build, operate, and maintain these services. So I always just think it puts a very fine point on the conversation when we talk about how that applies specifically to Pulse here. So I'll say history of Pulse in Texas. I'm I'm going to put Nora on the spot a little bit because I'm not the most authoritative person on this call to talk about where this all began, and Nora is. So I'm going to hand off to Nora at least to start us off down that path.
Sure, George, thanks. As I mentioned in my outlay, during Hurricane Katrina and even to a certain extent during Hurricane Rita in 2005, it became very clear to us that there was no mechanism for providing this sort of information to emergency shelters. And anyone who's ever heard me talk about this has heard me tell the story about having the evacuees in the Astrodome in Houston, and we were showing them pictures from the physician's desk reference, asking them if they recognized their blood pressure medication, because we brought some of them out of Louisiana on Black Hawk helicopters with no possessions whatsoever. So to Leslie's point earlier about an evacuee in a disaster may only have a day's worth of insulin, we had nothing. And this was you have to remember, this is pre-high tech. So THSA was actually created out of the disaster response use case, which makes it the perfect home in Texas for Pulse. So we put THSA together while the concept papers were being written by our colleagues like Lee Stevens for the concept that became Pulse, and all the support we've gotten from both the Office of the National Coordinator, staff from CMS to build this and put this together. So we started moving it forward over the last few years, trying to figure out what the right location would be, trying to figure out the right use cases. And I don't want to spoil any of George's thunder, so I'll let him talk about the specifics. But I will say, I think the thing that is important, and some of these questions that I'm seeing and listening to about, appropriate use cases, you really do have to build to your audience. And one of the things I've been telling stakeholders a lot lately is please read the room. I know everybody's tired, but please read the room. Please kind of understand your local emergency response politics or your state politics or your layout. I think we've gotten a lot of support because the hurricanes, and really even moving forward to Hurricane Harvey, left a very permanent footprint on our state. And really are things, I mean, it's funny, Texans can't do snow, but boy, we can do other disasters and we can do them really well. Just don't talk to us about snow or ice because we're not capable of handling that. So we have deep roots with this. Very exciting to move it forward. And with that, I'm going to turn it back over to George so he can talk about the decisions we've made around implementation.
Yeah, thank you, Nora. That lays a perfect foundation. Again, I always say kind of ironically, like it was disaster response that led to the creation of the THSA. And then, right at the time we were created or shortly thereafter is when the High Tech Act came about and HIE more broadly was adopted across the country. And really the impetus at that time went for more everyday HIE operations, like how are we going to connect healthcare providers and governmental entities and things of that nature at the local, state, and national level. And disaster response was always still there, but it wasn't quite at the forefront as it was in the beginning. And I think that we had one or two major disaster events during that time, the biggest one obviously being Hurricane Harvey. And we did not have Pulse in place in Texas at that time. And there was still just this like Herculean effort by local health information exchanges, electronic medical record organizations, entities that provide medication history, and others that really did band together that put this kind of like patchwork in place to be able to provide access to electronic health information in these environments when and where possible. But I think it really spoke to the need for a statewide solution to this with proper governance wrapped around it to be able to cover that not just in major metropolitan areas, but in other areas of the state, or if you're set up in multiple areas across the state, being able to have a coordinating entity to do that instead of just relying on it happening in silos. So that's really what led to the adoption specifically of Pulse at the state level and with THSA. Just to build on some of the questions I heard earlier of both California and Florida, THSA also decided to adopt the Pulse enterprise model as opposed to the open source because while we are responsible for health information exchange across the whole state of Texas, we have a staff the size of Rhode Island. There are 5 of us total. So being able to support something like that without proper vendor support and other supports would be rather challenging. So we wanted something that would come more ready with less hands-on work on our part. So we've adopted that here in Texas. And with that, we can probably go to the next slide and probably even the next slide to talk about some of the use cases that we do have. So the first use case, I think, is the most obvious one, or the one that's most talked about, which is treatment and alternate care sites. And in Texas, 95% of the time, this is going to mean a hurricane has entered the Gulf area, has pushed residents in the Gulf area into other parts of the state, San Antonio, Austin, DFW, not into a hospital where they have access to an electronic health record system, but into an alternate care site, such as a church or a football stadium, where they don't typically have that access. Pulse gives that access in a remote and secure manner that can be accessed from a smartphone, a tablet, or a laptop. So this is a really big need. I'm always glad to see when Texas doesn't rank #1 in things like this. So very thankful to Jamie over in Florida providing the statistic that you guys do double us when it comes to hurricanes. I didn't know that it was exactly double, but that's a very striking figure, and that sounds just about right. So we set up this pulse system in August of 2020. I think we've been very fortunate, or I'll say very good news for Texas, not so great news for Louisiana. Between August 2020 and today, we've had some pretty close calls and some smaller storms, but most of those just moved a little bit east at the last minute there and traversed over Louisiana, and which we'll have more on that in a minute. But this system, we started off with the lighter weight version of Pulse that was available at the time, and we upgraded to the Pulse Enterprise version in between the 2020 and 2021 hurricane seasons. And with that, we can go to the next slide. So we do have this available. It's not currently in use in Texas, but this is something that would be in use at both the local and public and state level to public health officials such as epidemiologists, which would essentially to be able to leverage the same health information exchange infrastructure that Pulse relies on via the eHealth exchange for what am I trying to say? Case monitoring in response to things such as the COVID-19 pandemic. So that is something that we do continue to work with DSHS on and with other interested parties at the local level in some of the more major metropolitan areas for public health reporting, but it's not something that we're doing right now. Steve, I know you wanted to speak a little bit. I don't know, maybe this is the appropriate time for you to jump in and make comments.
Well, it's not so much that I wanted to speak, but just to reemphasize the strong partnership or the strong potential partnership between the health departments and THSA in using Pulse beyond just the emergency shelter environment, which we're doing with THSA, but also to look at support for case investigation. That's a really nice second use case that also helps serve as a ongoing tool to ensure connectivity is there, so that when you do have a disaster, everybody's kind of already primed, used to using the system, and that most providers are already connected, and that we haven't dropped a connection somewhere in the middle.
Yeah. Agreed across the board. So I do want to pause here because I realize I don't have use case number 3 that is uploaded into this slide deck, and my apologies for that, because I kind of lumped this in, but it's like a use case within Pulse that is a separate technology, and it is the family reunification function known as the emergency census. So this family reunification function leverages the state's ADT feed that we call EDIN, the Emergency Department Encounter Notification System. It's also supported by Audacious Inquiry, might be known as ENS in other states. So the purpose of this system is to allow site administrators who are using Pulse to be able to reunite lost family members with each other. So if you have a lost child who comes into one of the alternate care sites, says, I can't find my mother or father, then that care site administrator can act as an intermediary to be able to look that information up in the emergency census function to see if that person has been recently admitted, discharged, or transferred at a nearby hospital, contact that hospital and say, hey, do you have this patient checked in? I have a lost family member where we need to reunite them. That is the third function of Pulse. And something that was added on to that somewhat recently was the ability to essentially treat other alternate care sites where Pulse is set up as their own independent facilities where a patient has been, admitted or discharged, probably not a transfer. But that way it wouldn't just be like an ADT feed for hospitals that they're looking up, but they can look up to see, hey, I see that they're actually located in this other alternate care sites in this city. So it just really adds on to be able to help people in an already tough time, not just to provide health information to provide better health outcomes, but to reunite families as well. And with that, I know we got a few questions, and I think I'll run through them at the end because we don't have a whole lot more here. So we did have a recent deployment, and we can go to the next slide. And there might be a picture missing from that. As I said earlier, some good news for Texas, bad news for Louisiana is they keep getting hit with these hurricanes. So THSA HIE Texas Pulse recently deployed Pulse in Louisiana in response to Hurricane Ida. And this was a very unique situation that just happened to work out based on the stage that we were at. So the way end users come to us for Pulse in Texas is there's administrator organizations that could be organizations such as Red Cross, whom we're in talks with that Jamie mentioned as well. But there's one specific one that our Department of State Health Services suggested that we start with just because they're the just picture perfect group of end users. And it's a group called BCFS. And they are already contracted with the state to do disaster response planning. They come in, they set up the alternate care site, they're providing the care, they provide access to medical staff in the site. The only thing that they were missing was access to electronic health information. So we just directly worked with BCFS to be able to onboard and train them in preparation for any hurricanes that might come and hit Texas. Again, very fortunately, that did not happen during this last hurricane season. However, BCFS, they're not, I know it's easy to keep scrolling. They're not just a Texas-based organization, but they operate in multiple states, including Louisiana. So they needed to deploy in Louisiana. They called us on a Saturday night back in August and said, hey, can we use Pulse in Louisiana? I was very pleasantly pleased to see how many people can come together in an emergency situation so quickly. We got approvals from HHSE, DSHS, and coordinated with our vendor, coordinated with BCFS in a very short period of time, and we're able to greenlight that. And they were able to successfully deploy across 4 different sites in Louisiana in response to Hurricane Ida. And the way they're able to do this from a data source perspective is we leverage the eHealth exchange when we do this. So it does have the capability to pull back data, not just from within Texas, but data sources that are connected to the eHealth exchange in other states as well. And that's configurable. So we may be supporting residents of Louisiana, for example, who are evacuating from Louisiana, coming to alternate care sites here. So we may want to configure it ahead of time, specifically to account for drawing health information from medical facilities in Louisiana, or it might be just more of a local Texas-based response, so we can configure that as well. But because they did have that option to be able to get data not just from Texas, but from elsewhere, the scenario really came together quite well. So let's go to the next slide, because we did have, I'll say there were probably multiple, but we're still kind of working out what some of the lessons learned were, but we did We did learn one during our first deployment that it was right on the front end. Luckily, we were able to provide some help, but I'll actually go with two here. One, I will echo what both Florida and California said. It is super helpful to have boots on the ground to be able to assist end users with use of this system. Because it's being deployed in Louisiana, we are in Texas, we were not able to provide that boots on the ground help for them. We were not able to get into Louisiana based on conditions at the time to do that. So they were communicating with us via email, via phone, but it's always so much easier to be able to have someone on site right there that you can turn around and just say, hey, I need to figure out how to use this. And it might be as simple as just click on this tab or put information in this field. Whereas doing that via phone or email, that requires more coordination. So one of the things in the very beginning, we realized is that we weren't getting a return on a lot of documents. And it was because while this is covered in the training materials, we're going to make this more prevalent in the training. We're going to move them up from using an example, page 12 to page 1 or 2. And it is that we're drawing information from national health information exchanges. The big difference there between national and local is we're talking about a much larger volume of data and patients that are traversing this. So for patient matching purposes, you put in John Smith in a region, you might get several hundred results if that's the only thing you're putting in is first and last name. That's going to be thousands upon thousands on a national scale. So the more information that you can put in the demographics, the more refined results that you're going to get. There are a number of required fields, but for more common names and information, it's going to be helpful to put in even more information and get that information. And sometimes it may not return anything if there are too many duplicate results. So just knowing that and having that available, front and center in the training, or having someone who's boots on the ground to just tell you that is really going to help. And we were able to help on the front end and let them know right away. And, that was able to be fixed. But that's something that I would definitely say is a lesson learned that we can carry forward with us for future events. And
Great.
Yeah, with that, I'm sure we can perhaps tackle some of these questions.
Yeah, we will. We can go through a couple of these questions. I also want to be aware that we are standing between you and the break. So I do want to make sure that we pivot back to Rachel and Rim to answer a question around the auditing access and what's available in Pulse Community. And we'll answer one more question and take a break, and then we'll also address some of the other ones in the breakout. Rim and Rachel?
I can go ahead and touch on that. There was a question, I think it was to Florida, about auditing access. And I'm not going to take you back to the discussion we had with the pinwheel of different functions, but if you can picture that in your mind, there are a few places where that enters in. First, under policy, to ensure that you have policy on what access is appropriate. On technology, Pulse Community logs all events that happen on the system. So that means that it does make a positive log of queries and retrieve documents. Under training, you need to think about that. You need to make sure that your users know what is an appropriate use of the system. And under operations, it's going to be important for states or communities that are implementing Pulse to also implement the controls that monitor what ends up in the audit log so that they can monitor for inappropriate access and address that.
Great. Great, thanks for that additional information, Rim. I do want to answer one of the questions that we have in the chat, and we will get to some of the other questions when we go through some of the interactive breakout sections and then the final discussion. But one question I wanted to ask all states as they were implementing, Chris Baumgartner from the state of Washington asked a really good question in chat around, can any of the states share their implementation costs and their annual operational costs for Pulse?
I'm sure we can, but I want to get it right. So I can follow up with that information, Kate. And I'm sure that can be disseminated with materials. I just don't have the exact amounts here in front of me.
That would be the same for me for California. I need to pull that. Also, one of the things I can also provide is I have to have staff that work for me to be able to do a lot of the coordination as well. So that's also an additional cost, and I can provide, what my PYs generally cost me and my overtime cost, also for deployment times.
And perhaps a better question is not specifically the dollar figure, but what are those costs that you have to consider? So it's not only the, the leadership costs, your staffing costs, the technology costs, like what are the other additional costs that should be considered when kind of estimating Pulse implementation?
Your budget, yeah, definitely.
And I can break that out generally, under the high-tech era, which just very recently ended, a lot of the money that went to states for this was for infrastructure development. And when we're talking about programs like this, that's for acquiring and implementing software service platforms to be able to actually exchange the data and do that work. What some states, Texas included, have transitioned to now that we're past the high-tech era is into the MMIS, MES era, which pays for ongoing maintenance and operations. And again, that's heavily around the software that supports these systems, but then there's staff cost. And when you're talking about disaster response, as Leslie mentioned, that can quickly tick up as well.
Great. All right, I'm going to go ahead and pass it over. We are documenting the questions that you asked, and we'll make sure to get to those, but I want to be aware of the break. So I will pass it back over to Chrissy to kind of give the little run of show and next steps for the workshop.
Great. Well, thank you again to our panelists. Really appreciate you sharing your experiences. So we're going to pause for a couple minutes to give everyone a chance to get a drink, stretch their legs, and then really hope you'll come back so you can participate in our breakout groups and discussions that are to follow. So if folks could come back, we're going to start back up in about 5 minutes. So right around 3 o'clock. So take a break and come back to us in 5 minutes. Thanks, everyone. Great. And as folks start to trickle back in, let us know if you're back. We'll be restarting in just a moment. And you can let us know by thumbs up or by chatting in that you're back. Great. See a bunch of thumbs up. Great. Okay. Hopefully folks have had a chance to get a drink and stretch their legs, and thanks for coming back. Yeah, thumbs up if you're back. We're going to go ahead and get started. So we are doing small group breakouts. So I wanted to set the context for the discussion at the first part of our call today, give a chance to hear from implementers, state implementers of Pulse, and now we want to get into some smaller group discussions. So for those smaller group discussions, just really wanting to hone in on, talking about what is the ideal state of Pulse community, this type of solution to support disaster and emergency preparedness in your locality, discuss potential barriers, potential strategies to address those barriers, requirements for technical implementation, other opportunities and considerations, and for collaboration and support. And then the way we're going to do this is we're going to break into 3 groups, and we'll have the 3 groups using Mural. For those of you who aren't familiar with Mural, this is just a way to collaborate with each other, and your facilitator will give you a walkthrough on, give you a link and give you a walkthrough on how to use Mural when you get to your breakout group. But again, going to be focusing in on, hearing from you on what your needs are, what an ideal state for, having for Pulse community could look like, those barriers, opportunities, collaboration, and consideration. So we'll do this in Mural. And we're going to go ahead and get started with pushing people to a breakout room. There's going to be 3 breakout rooms that will be launched in a moment. You'll have an EMI facilitator in each of the breakout rooms leading you in the discussion. Really want to hear from everyone. And we'll also have a state panelist in each of the breakout rooms so they can continue to contribute to the discussion based on their experiences and learnings, and folks can continue to have an opportunity to ask them questions. So in a moment, Brenda from EMI will be sending everyone to a breakout room. You'll see a little pop-up that invites you to join that room. Please click the join, and your facilitator will get you started in just a moment. So Brenda, I will let you start sending folks to the right place.
And let me know if you're having trouble seeing your breakout room.
all.
Great. So welcome back, everyone. Thank you all for participating in the breakout rooms. We are going to go ahead. I'll put the slides back up. We are going to go ahead and close out our today's session workshop with a discussion on the future of the Pulse Initiative and Pulse community, kind of drawing from some of the discussion that just happened in the breakout groups. So I will hand it over to Rim.
Well, I know that we had a good discussion in our group. It was a small group, but we had a lot of things to talk about. And what we're hoping is that people would just volunteer some of the things that they either voiced in their session or they heard in their session that they are good learnings outside for the larger group. And I would encourage people to either drop something in the chat, but especially I think that it would be really useful if people want to raise their hand, come off mute, and just talk a little bit about what they heard. Does anybody have anything that they'd like to share? What were key takeaways that you had? You do know that if nobody volunteers, I'm going to start calling on people.
Rim, I'll volunteer first. So I listened in on Chrissy's session, and we talked a little bit about the possibility of pushing Pulse community out into the open source community, and there was a gentleman on from a state who said that they don't think that that's too much of an issue in regards to it being in the open source community. It's more or less that states don't have the bandwidth to kind of take on an open source kind of product in-house, like they would hire essentially a vendor of some sort to be able to do it. But it's good to hear that there wasn't a direct barrier from the state in regards to like a policy decision or something like that.
Thanks, Rachel.
I have a quick question. This is Dave from Arizona. Does the Pulse or ONC have an equity policy, for example, class, culturally, linguistic, applicable services standards that they have to follow, or would recommend developing to help states that want to explore that area more in depth?
I could say that I don't think we have that. I mean, other than, you know, products have to be like on a website, they have to be 501, 508 compliant, but we don't have anything in regards to linguistically. I'm not sure, but that's something that's a good thought. Yeah, thank you.
I guess what I'm getting at is when you're using Pulse and an individual is trying to access a particular patient or resource, you know, there may be certain cultural restrictions that, you know, would apply that may not be known. So maybe it's different for the contact point, but I don't know, with all of our federal grants coming down, class seems to be a major approach, that you have to have a class policy in place and how you deal with either its language, how you present material, who presents it, when. So I just thought I would mention that and see if there's any other out there.
Yeah, and it might be something to look at in doing sort of like a best practices or something around that, on how to, you know, best provide the information or ask patients about information regarding, you know, their health history or something like that, and to confirm stuff or ask about medications. Yeah, things like that. Yeah, appreciate it, David.
Rachel, this is Steve. I'm just thinking about that in the US CDI and SVAP and what's coming down the pike. There may be some opportunities to leverage future iterations of the US CDI that include some of that information as potential triggers to be displayed in the Pulse interface.
Thanks. That's a
Yeah.
great suggestion.
That's
This
a
is
great
Leslie
suggestion. Thanks,
from
Steve.
California. Couple things that came to mind a little bit off topic, but in our newest version of Pulse, we had to make sure it was ADA compliant. And one of the things that we had to change, which was a big change for me, in the way I also train, is one of the ways when you're retrieving the document and originally caching it and moving it forward is you follow the green button. Well, we had to change it. We couldn't have a green button anymore because that doesn't meet visual compliance. And so, you know, I think these things are good points, but I think you can definitely within your training and usability adapt it to meet cultural as well as all different types of compliance needs. It's just about being sensitive in your trainings and use of it.
Thanks, Leslie. Chris, you've had your hand up.
Yeah, thanks, Rim. I was just going to remark on something that Rachel had said about, from their breakout session, the focus on open source. In California, IT procurement policy requires consideration of open source solutions, and also cloud first is an IT procurement policy. So I think that, and I've heard of that in other states as well. I absolutely agree with whoever said it would probably be challenging for the state teams to absorb that type of work, and it would probably be farmed out to a vendor consultant. But I do think that legislatively or procurement policy-wise, states are becoming more open to that, especially for federally funded systems, which also requires reuse and sharing. From my breakout, the one thing that I wanted to highlight for the group, we talked an awful lot about increasing or raising awareness of Pulse as a thing that exists, and making sure that all of the parties that might eventually leverage that or need to leverage it during a disaster response are aware of it and aware of how to use it, including multi-agency coordination and all the different roles and standing it up and mobilizing that. So that was, I think, one of the key things that I took away from our breakout is it's a powerful tool. It'd be great for a lot of people to understand how useful it is. Thanks.
Thanks, Chris. Kristen, you have your hand up too.
Yeah, I was just dovetailing on that. 2 points is, I think one of the questions is whether or not as we look at the profile, is that something that I don't think it is currently in there, but if there's language that would actually help with the class part that they were talking about, that you would be able to pull that, so that increases likelihood that you can help communicate in an appropriate language. And then the same thing is really, I think the cases are at a place that there could be a pretty robust conversation across other public health organization officials and senior officials across the country to build their understanding of this. And also from that, also recognizing that I think COVID has taught us all that the healthcare system and surge, the layperson is now understanding what surge kind of is in its rudimentary format in their viewpoints and such of what they learned. But, we're at a point now that we can see a healthcare system in duress. And this is an argue point for this, leveraging this in a disaster, because it can actually reduce the likelihood of more surge, and has been demonstrated to do it, as demonstrated in other parts of the country. So I think we're in a good point where we can show true examples and leverage that and help people think that this isn't as far off as they would assume it would be.
Thanks. One of the recurring themes that happened in the group where I was opportunities to collaborate across the states. In some cases, very specific to community. So for instance, collaborating on modifications to the code base, collaborating on an implementation guide that might be beyond just implementing the technology, but best practices on the policies, operations, et cetera, some of the other things that surround Pulse. I don't know if anybody in my group wants to expand on any of their thoughts there. And then Kate or Chrissy, I don't know if there were any recurring themes in your groups you'd like to raise.
Yeah, absolutely. We, in my group, we talked about opportunity to collaborate with the Incident Command Center and NIMS and expand that to help kind of communicate and grow. Also, the National Public Health Service, which is the Uniform Service of Public Health, could be an opportunity for collaboration. And also for collaborators, Red Cross seems to be ubiquitous across different states and in different situations. So that could also be an interesting collaborator. And then also thinking about maybe even Coast Guard, you know, some of the different places have Coast Guard that could be. So I think being really creative and how what different roles and responsibilities of different people and how to take advantage of that. David also from Arizona mentioned tribal nations in Arizona. There's 22, 26, I can't remember the number of tribal nations. So that just might be, and there's an Intertribal Council of Arizona. And so there just might be some collaboration with some of the tribal nations as well.
Thanks, Kate.
On the collaboration point, I can just add from our group, we had a couple of comments about public health agencies. So just a lot of emphasis on partnering with public health and also academic institutions are kind of the big takeaways for us.
Okay.
Anything else that anyone wants to share?
Kate was our leader for team 2, so heads up for team 2.
Yeah, there were some really good responses. Some of the things that we did identify is like some of the barriers and strategies, and maybe this is an opportunity for collaboration, but you know, just really getting consistent about the privacy policies to be considered. Also, how does that align to like state executive orders for declaration of disasters, which might allow some superseding of some of those privacy policies, and collaborating with the National Public Health Law Center to maybe help support some of the, you know, privacy policies in those emergencies and disaster situations. Also, some of the barriers, which I think most folks will have understanding of it, you know, the rural access and the access to broadband and internet is going to be always something to consider in these situations. And then they also identified some different recommendations from ONC around success stories, continuing the peer-to-peer community case studies and sharing those materials. It's going to be really important to continue to document the success stories to make sure that Pulse continues to grow and as folks are aware of it.
Great. Thanks, Kate. Well, I don't see anything else. Chris, it looks like you came off mute. Did you have something you wanted to share? Maybe not. So Chrissy, I think that we may have gotten a wrap there. We've, yeah, I'll turn it back over to you to wrap us up.
Rim, could I add one real quick comment? This is
Certainly.
Jamie from Florida.
Sure, please.
I will say that the Pulse, the COP is a great resource, and I think all the other states would say the same. It's nice to kind of walk through these trenches together with other states as we try to figure it out and lean on. I think we get the most support out of those sessions. I believe we meet monthly. But the team is always very engaged, and you know, that's where you see George and other states that are participating, and it is growing. So I just wanted to throw that out there as a resource. I don't recall it being mentioned earlier, but I want to make sure folks knew that community does exist and is out there to support this project.
Thank you.
Sorry. Great. Thanks so much for that. Sharing that. And so now we're at our wrap up. Thank you all for sticking with us for the last couple of hours and engaging in discussion. We're just leaving you with a couple of resources, and we'll be sharing the slides after the workshop, but we wanted to make sure we shared here the email address for reaching ONC regarding Pulse Community ONC can work with anyone interested to get access to the GitHub. And then there is, of course, the ONC Pulse Initiative website, which has a lot of additional resources and information. And with that, I'm going to go ahead and turn it to Rachel Abbey for closing comments.
Great. Thanks so much, Chrissy. I just want to say thank you all so much for hanging in there with us. I know it's been a long day. We really, really appreciate all of your feedback and comments. It's super helpful to hear from the field and to gather your input. And hopefully, you know, some of these things can be put into any sort of updates or additions to Pulse in the future and Pulse community. I also want to especially thank my EMI colleagues and their excellent facilitation and guidance of this workshop and listening session. I think it went really well. And I'm going to put my email in the chat. If you all have any other questions or comments or thoughts, please feel free to email me. And we're also happy to come and talk to your state and your community in particular about Pulse and provide, you know, sort of options if folks are interested. So thank you. Thanks, Chrissy. Appreciate it.
Great. Thank you, Rachel. Thank you so much, everyone. Thank you to our state panelists and everyone who participated. Have a good rest of your day.
Yeah, thanks, guys.
Thank you.